I can turn the music back on if you want. Okay, I will. The mic is definitely working, so.
We're just testing the sound to see if the folks online can hear. So if you give us a thumbs up or in the chat, let's know. All right, thank you. Well, good evening, everyone, and welcome to the Sherwood B. Winslow MD Distinguished Lectureship. I'm Angela Stewart, the Director of the Population Health Alliance of Calhoun County, and I get the opportunity to welcome you all tonight in person, which is extremely exciting, in this beautiful space. So if you haven't had the chance to be here yet, it's gorgeous, isn't it? And then also welcome everyone who is online joining us. So everyone in the room is aware we have folks that are online that might be asking questions, and our other staff member, Cicely, is going to be fielding those. And so we'll bring them into the discussion at the end. A couple housekeeping pieces. If you need restrooms, they are in the back there, and just through those double doors. So I'd like to just thank everyone for coming tonight. Between the Population Health Alliance and the Battle Creek Community Foundation, we are pleased to have you all here in person. Tonight is an exciting night, as not only do we get to be in person for the first, I know I keep saying in person, but it's like we get to be in person, right? For the first time in over a year, and we get to hear from Dr. Rieder on the opioid epidemic, more about our WMed residency program, and we'll also take this opportunity to celebrate the announcement of the 2021 Dale G. Griffin Healthcare Leadership Award. I am pleased we have with us this evening Kathy Griffin Lake, so thank you for attending, Kathy. And here to present the award is Bill Winslow, a friend of Dale Griffin, a previous winner of the award, the son of Sherwood B. Winslow, and a dedicated advocate for improving healthcare in our community. So.
Thank you. Thank you, Kathy, for coming. And I want to introduce my wife, Nancy Winslow, over there next to Kathy, and my daughter, Elizabeth Winslow Amesbury on the left. So that's the family for tonight. And the Dale G. Griffin Healthcare Leadership Award was created to honor many contributors and longtime healthcare trustee and community volunteer Dale Griffin, who passed away in 2001. The award is given to recognize exemplary contributions to improve the quality and accessibility of healthcare in the Battle Creek community. A committee of healthcare leaders has selected Ruth Clark as the 2021 Dale G. Griffin Healthcare Leadership Award. Unfortunately, Ruth is not here tonight, but I think she's online, and so at least we hope she is. Ruth has been the executive director of Integrated Health Partners since 1999, supporting over 200 independent and employed providers, including primary care and specialists, with a community member impact of over 100,000 patients. Ruth has grown IHP from a primary focus on health plans, contracting to an organization focused on the aim of better outcomes, lower costs, improved patient experience, and improved clinical experience. Ruth has led IHP through a major new initiative by acting fearless in the face of change, using innovation to deliver services that were new in the industry. Examples include the introduction of provider-delivered care management, moving upstream learning, collaborative population health programs to address disease prevention and management, and empowering others to self-manage their healthcare or continue to grow their healthcare experience through education and hands-on experience. Like I say, she is currently out of town. And she is also currently serving on the TCC Leadership Cabinet and working closely with the Population Health Alliance to help chronic disease work to impact one of the priority areas of 2019 Calhoun Health Needs Assessment. Although she was unable to attend, she's, like I say, online. And it's an honor that we award Ruth the 2021 Dale C. Griffin Healthcare Leadership Award. And thank you for all your tremendous contribution to our community. I don't know where she is, but she's there.
Thank you, Bill, and we will also get this award over to Ruth as soon as she's back in town. Oh, there she is. Can she say a few words? Ruth, would you like to say a few words?
Oh.
Oh, you're muted.
You're muted.
There we go.
I think the speaker.
Okay, all right. Thank you. This is such an honor and it's a big surprise, honestly. I really appreciate that. I've really enjoyed and had the privilege of working with a lot of really great people over the years. It's been my privilege to work with our fantastic team at IHP, with our physicians and their practice staff and with our community partners. And I'm hoping in retirement that I'll be able to continue to contribute to the work that's going on in our community. It's very important, and I've been really engaged and enjoyed that piece of the work that I've been doing. So thank you so much.
Thank you, Ruth, and for all of your partnership and exceptional work in healthcare. Now we would like to take a moment to appreciate our partnership with WMed, because we know that graduate medical education programs generally increase the quality of care in a community, instill a social conscious and dedication to care for our most vulnerable populations, and provide a greater access to care. I would like to introduce Dr. Holly Neiman-Hart, Program Director of WMed Family Practice Medicine Residency, to introduce the residents we have here tonight. Holly.
Hi, it's really nice to see everybody in person again. I've done this now for a couple of years. This year we got to our full complement. We have 18 residents and we're in the process of getting ready to recruit for our first class. We will graduate our first class of 6 in June of next year.
Okay. Gotta get the window.
I put this together on the way over because I was working inpatient today, and 2 of our first year residents are not here quite yet, but I know they were planning to come, but it was a very busy day. So we could have the next slide, please. These are our 6 new first year family medicine residents who will graduate in 2024. And we have 4 of them here. So over here we have, no, I guess we only have 3 of them. No, okay, 3. So Suga, would you like to introduce yourself? And tell them why you came here.
Hi, my name is Suga. I'm from Toronto, Canada. I've been to university a few times before, and I found that it was important for me to be part of residency program.
It was important to me to be a part of a residency program that worked with the FQHC, because that's where most of my experience is during medical school, and also a program director that had a career before medicine, because that's how my career trajectory has been. And so I know that she has an understanding and she values our unique experiences and life experiences that we can bring to the program. So it's been great so far. Everyone's been very welcoming, and I've enjoyed myself so far, and I look forward to learning as much as I can. Thank you.
And this is Abbas Makhtari.
Hi everyone, my name is Abbas. I'm also from Canada. Windsor, which is a city across the river from Detroit. I used to live in a big city, Montreal, which is like a few million people there, but we moved to Windsor. It was a very small community, just like Battle Creek. My wife and I and 2 little kids, this is what we do about that community. Battle Creek really reminds me of that. The first day that I had the interview with Dr. Mahard, I knew this was the program for me. Although I applied to other places, but I did put the Battle Creek WMed at the top of my list, and I'm very fortunate to be here. I don't know what the future will hold, but I would love to, somehow, some way, end up being here or close to here, as a part of, this community and this program giving so much to us. I would like to give back in the future as well. So really appreciate what Kellogg family has done for all of our residents here, especially the ones in Milton, and we really appreciate it. Thank you.
My name is Sweta, and I'm from Canada. I'm so glad to be here, and family business Battle Creek was my first choice. I would be happy to work in a community and with a family, like family business here. And yeah, I always wanted to be a primary care doctor and be a family doctor. I'm so glad to be here. Thank you so much for everything.
Hey everyone, my name is Blake Tuma. I came from Detroit here to Battle Creek. I would like to thank you for your support for our program. I'm very proud to be here and for the opportunity that we have to serve the community and help everyone with our knowledge and our effort. Thank you so much.
Hello everyone, my name is Priyanka. You can call me Priya. I'm also from Canada. So for me, this was my first choice since I met Dr. Nanitha during the virtual conference. I knew this was the program I'm going for. And after learning about the community, serving the underserved and dealing with the complex pathologies, that was my first choice. And I'm very happy and lucky to be here serving the community. Thank you so much.
And then we have one additional resident here who is Dr. Shakurian. And Dr. Shakurian is one of our 3rd-year residents, and he's actually one of our chief residents.
Hello. It's very nice to see you all again. I'm one of the first group of residents. I was in the first group of residents who joined the program, and I'm truly honored to be here. Past 2 years have been great. I had the privilege to work at Graysoft, serve the community, and this larger field. I would like to stay and keep serving the community. The reason I joined the program was first Dr. Nyman, second Dr. Nyman. I can't thank her enough, and thank everyone in the community for supporting us, giving us everything we need to really succeed. Thank you very much.
This has actually been a pretty long journey, at least 10 years of work to bring this to Battle Creek before I got here. And we're the first residency from WMed that's away from the mothership here in Battle Creek. And we have such great support in the community. And we are unique at WMed because we're sponsored predominantly by Bronson Battle Creek, which is new to education, by Grace Health, which is our outpatient center, and also we're a WMed residency. So we have lots of great support. The only thing I can say is sometimes going from secured network to secured network online is difficult, but it's okay. We're making it work. And so I also would like to thank everybody for making us feel so welcome here. And I brought my husband with me. I bring him every time. So, all right. Thank you.
Thank you, Dr. Mahard, and thank you all for being here. Now, in honor of Dr. Sherwood B. Winslow, MD, I would like to introduce a partner in providing this high-quality event. our colleague, Dr. Lisa Graves, Associate Dean, Faculty Affairs, Office of the Dean at WMed. Lisa is joining us virtually and will be introducing tonight's guest lecturer. You're muted.
Okay, thank you. Just to let you know that those of us online need to be unmuted in order to speak. It's a pleasure to welcome you both in person and also virtually to this presentation tonight. Dr. Rieder did both his doctoral training at Georgetown University and as faculty at Johns Hopkins University Berman Institute of Bioethics. Travis Rieder, PhD, has published widely on a variety of topics in philosophy and ethics. His interest in opioids came about suddenly after a very intimate run-in with the American healthcare system left him with a profound dependence on oxycodone. In the wake of that experience, he's become driven to discover why medicine is so bad at dealing with prescription opiates and how that problem is related to the broader drug overdose epidemic. His first article on this topic in the journal Health Affairs was one of the most read essays in 2017 and was excerpted by the Washington Post. Since then, he has written and spoken extensively on the topic, both for scholarly and general audiences. Accumulation of his first 3 works of research on the topic is his book, In Pain, A Bioethicist's Personal Struggle with Opioids. I've had the opportunity previously to hear Dr. Rieder speak, and you're in for a wonderful presentation this evening. Thank you very much.
Oh no, the bad thing happens. The microphone worked earlier and now it's not working. 1 second. Okay, testing over here. Is it coming through? Yes. All right. And we have a clicker, I believe. Awesome. This is so wonderful. It's so nice to be around people. It's so good. And we have a slideshow. Good to go. Okay. Thank you all so very much for coming. And thank you to the sponsors for bringing me out, for Dr. Graves, who I met years ago now. And she immediately said after my talk, "You're coming to Western Michigan." I said, okay, sounds like fun. So I'm very excited to speak with you all tonight. I'm going to give you a kind of world. Is it not coming through still? Oh, no. Oh, it paused itself. Testing? Is it coming through? Oh, man. No more technical glitches, please. All right, I think I even have a clicker that works now. Anyway, thanks. Thanks to everybody who made this happen. I'm going to give you a kind of whirlwind tour tonight. I'm going to start with a case study that, as you heard, is I've got a lot of details for it. It's a really rich case study. I have a lot of details because it's my case study. So I'm going to tell you a little bit about something that happened to me, and then I'm going to use that story as a vehicle to try to extract some lessons for it. So I found myself in this situation where I had an experience, I had this intimate run with the healthcare system, but I'm also a professional bioethicist. I work at Johns Hopkins, and it seems irresponsible not to tackle this problem and try to think about it a little bit. And so that's where we're going to go from here. So here's part 1, this very personal case study. On May 23rd of 2015, which was Memorial Day weekend, Saturday of Memorial Day weekend, I had big plans. That was the goal for the day. Motorcycle enthusiast for many, many years. I love to go down to Shenandoah Valley. This is Skyline Drive. That was the goal, several hundred miles away. I made it about 3 blocks of that several hundred miles, and 3 blocks down from my house, still in my neighborhood, young kid, hadn't had his coffee yet, blew a stop sign, hit me squarely on the left side of my motorcycle, and my left foot got crushed between the bumper of the van and the fairing of the motorcycle. So this was the goal. What happened instead was this. So this was the first X-ray I took of my foot. I know that not everybody in here is a radiologist, so I'll just tell you, That's not what a foot is supposed to look like. It's supposed to have rather more straight lines. So that the first metatarsal, the bone that connects to the great toe, shattered, and it exploded out the inside of the foot. So I was crushed for just a second, thrown from the motorcycle, and as soon as I hit the ground, I knew I was in real trouble. Slid to a stop, ripped off my armored boots, and I could see bone, I could see tendon. It was very, very distressing. What I did not know at that moment, I'm not an MD, right? So I've not gone to medical school. I fairly limited my understanding of traumatic injury. What I did not know is that I was in what they call a limb salvage situation. So I was going to be in for a series of surgeries if they deemed my foot salvageable. But the trauma surgeon that I saw first that day, he would tell us about 2 days later that he did not expect the foot to survive. They could do something called a transmetatarsal amputation. It takes the top half of the foot, or if too much of the tissue dies, they have to take the whole foot. Not great news. It was a very, very scary time. Now, see, when I was doing all the talks on Zoom for the last couple of years, I could hold you in suspense. I'd be like, you don't know whether I still have my foot. It's harder to do now, strutting around the stage. So spoiler alert, I get to keep my foot, which is really great now, but it was a really long road. So getting from there to here, there were 5 surgeries that had to happen right away. Those were the limb salvage surgeries. There would be more down the road. They would try to turn my foot into something that looked foot shaped, but there were 5 surgeries is what it would ultimately take to bring my foot back together. And so the first 3 were orthopedic surgeries. The trauma surgeon would pull all those bone shards together, hope that they knit, and really just kind of hope that the tissue was still alive, that it was still being vascularized, that there was a blood supply. And there was a lot of waiting. I would have a surgery. I would sometimes get to go home for a few days. But there's this problem, and I know it sounds silly, but I had never really thought about it before. I had a hole in my foot, and that's a problem. Like, you're like, yeah, no kidding, it's a problem. But I mean, I'd had deep cuts before, I'd had injuries, and when you have your body gets opened up, you have to sew it together, you staple it together or something. But if you lose a big chunk of flesh, what do? Turns out it's a problem, which is one of the reasons they thought they might have to amputate the foot. But there's a very cruel surgery that I had never heard of, which is called a free flap. And a free flap is when a team of doctors, several teams in my case, take a variety of tissues, whatever is needed in that moment, from one part of the body, and they cut it free. So it's not an attached transplantation. They cut it free, and they use that tissue to solve the problem in another part of your body. I don't want to lose you with the technical jargon here, but they cut open my thigh and plugged the hole in my foot with it. That was what happened next. That was surgery number 5. I happened to be in the Baltimore, DC area. All these surgeries took place in 3 different hospitals, world-class hospitals, world-class doctors. The way I try to think about it, as I think about what comes next and the failures that came next is, I mean, they made my foot out of my thigh. Like this was really impressive medicine, right? So they took muscle to cover all the bones, because the bottom of my foot, it has to bear weight. They took fat to pad the area. Skin would have to cover it all, so they took skin. And it's so much tissue, it needed its own blood supply. So a pulmonary team come in and take an artery from the thigh, do a microsurgical transplantation. Then a nerve team come in after that, because they thought I might want to feel the bottom of my foot someday. You know, step on something sharp, step on something hot. So they had a nerve team come in, clip a nerve out of the thigh, transplant that in the bottom of my foot. It's a big surgery, 8.5 hours. After those 5 surgeries, I waited 5 more days in the ICU, 5 days on the floor. At this point, we're about 4 weeks out from the accident. 5 surgeries, lots of minor procedures in between. And what I had never given a second thought to is all the pills they were giving me. And I mean, not give a second thought to, that's not quite honest, because I really needed them. So I like screamed for them sometimes, and you know, got a little upset when I was under medicated. Like after that 5th surgery, they just didn't alter my medication. I had this massive new wound on my thigh and was really under medicated. So I was definitely aware of the fact that I needed massive painkillers. But what nobody talked to me about was They were escalating the pain medication over the course of weeks. I was on around the clock dosing. I had surgery every few days. And so I was re-traumatizing the wound and experiencing fresh post-surgical pain, the kind that you just don't medicate very well with anything other than opioids. In between surgeries, I had a hole in my foot. So I mean, you're not going to hear some of this. Maybe some of you heard, please, close your ears. But like, they have to like go in and cauterize bleeders in my foot, right? They have to take sponges out of this hole every day so that it doesn't get infected. It's the stuff of nightmares. And the only advice I got this whole time is don't get behind the pain. You get behind the pain, you get in trouble. So don't wait until you're in excruciating pain to take more pain meds. Oh wait, there was one more other piece of advice. Every clinician was very worried about my bowels. They were really worried about constipation, which there's good reason to be, because if you get too severely constipated, you need a bowel blockage, it can be an emergency situation. But that is the only worry that they had for me. Okay, so fast forward. I finally get to go home 10 days after surgery 5. I go home with a ton of meds. Since there are some doctors in the room, you might want to know the numbers. So I had gone from being opioid naive, not having had any opioids on May 22nd, 2015, to 8 weeks later on about 180 to 200 morphine milligram equivalents. And so for those of you who don't have context for this, the CDC now says, try not to go past 90 MMEs, 90 morphine milligram equivalents. So I was on about double. And there are lots of people who are on more than 90, and I should talk about that a little bit later. But it's quite a lot to get to over the course of several weeks. So I go home, I continue to take meds. My prescribing doctor says you're gonna get a tolerance. That's already been happening. We've already been escalating the dose. When that happens, tell me, I'll prescribe a higher dose. So I'm on extended release oxycodone, so OxyContin. You've heard that one before in the news, right? Immediate release oxycodone. I'm on gabapentin, which is a non-opioid, but it's a special painkiller that we think is better at treating neuropathic pain. So that's for that nerve they clipped out of my thigh. And I go home and I'm just a really good patient, y'all. I did not get behind the pain. I watched the clock, and every 4 hours I took more oxycodone. And I went in for my first checkup with my trauma surgeon since like week 2. I hadn't seen that guy in a long time. He pulled my bones together and handed me off to plastics. But now I get to have an x-ray and see if I'm ever going to walk again. It's very exciting. And so I go in super upbeat. He's asking me all the questions. He's an orthopedic surgeon, so his back's to me and he's typing. So orthopedic surgeons, right? Their time's worth a lot of money. It's working really fast. And so he's going very fast. And he asked me the routine questions: how much pain are you in? What are you doing for it? And so like, yeah, so the OxyContin, 40 milligrams a day, oxycodone, 60. And my wife, Sadia, she and I are kind of doing the math. And oh, they've got a penton too. Doing that like 6 times about 1,800 milligrams. And he just stops. And he turns around and says, that's way too much. It's been way too long. You should be off everything by now. And this was 2 months from the accident. And he was literally the first person to show any concern about my pain regimen. So we said, okay, how do we do it? A little bit concerned because I'd already dropped 1 dose of the gabapentin, just so I had to wake up at night to take it with pain. And when I'd done it, I'd experienced some pretty nasty withdrawal. So doctors often don't know this. They think gabapentin doesn't cause withdrawal. It's just a non-opioid. It causes pretty nasty withdrawal. And it's well documented in the literature. It turns out it's just not very well taught. And so I was a little bit worried. And he said, that's not my problem. I'm paraphrasing. But he basically was like, I haven't been writing these prescriptions. Go to whoever's writing the prescriptions. So that was my plastic surgeon. So I went to him next. And we asked the plastic surgeon, how do I get off the meds? And we should have known we were in trouble when he like did the thing where he looked for the answer in his eyelids. He was like, ah. He didn't know what he was talking about. He would admit this later, but he gave me the following advice. He said, all right, take everything you're on, the OxyContin, the hydroxycodone, the gabapentin, to divide it by 4. And we're going to drop 1/4 of everything each week for the next 4 weeks, and you'll be off in a month. We didn't know any better. So we said, okay. And just in case like some of you get tired of listening to me talk and you leave in the next few minutes, I just want to jump to the punchline to make sure you don't miss this. That was terrible advice. So if you wanted to torture your worst enemy. A really good way to do it would be to get them deeply physically dependent on opioids and then give them that tapering regimen. And the reason is because it's a 25% dose reduction to start. We'll come back to that. And it's more than enough to send someone into acute withdrawal, especially if they're very sensitive to it. Everybody's different. We're all on a bell curve. Turns out I'm not here, it looks like. So more than enough to send somebody into really severe, nasty withdrawal. The standard advice now that's slowly emerging from the literature is you start with 5 to 10%. Some people like me will still have withdrawal at that rate, and you slow it down and you pause, right? So we did 25%. But the thing is, it's not cold turkey, right? So you're gonna have to do it again 3 more times. So the reason it's the worst advice possible is because you're gonna make somebody sick really severely, and you're gonna keep them that way for a month. And that's what happened to me. So this is not a live button. I'm not gonna click play and have you watch my TED Talk. That would be super awkward. I put this up here because I'm gonna give you kind of a quick version of what happens next. I get a lot of requests to give the withdrawal talk, where I tell people what withdrawal feels like. And it's kind of awful to do. And I used to like put my soul into it, and it just drained me every time. So now I told the TED folks that I would put my soul into it for them, and they could use high-def cameras and good microphones. And now it's open access for you, everyone. So if you want to share this with anyone, 14 minutes, you can hear the horror story of what withdrawal's like. I'm going to give you the academics version, the kind of high-level version. So what happened next? I went home and I dropped 25%, and the process started. So later on, much later, beginning of 2017, I would publish my first paper where I told a little bit of my story in the journal Health Affairs and used it to make a health policy argument. And the artist came up with this. So the artist reads the essay and then they try to come up with an image to go along with the cover for that issue. And this is what the artist came up with. And I was like, you know, you're the first person who I think understands what opioid withdrawal is like. That's it. So here's what happens when you go into withdrawal. So in general, kind of basic heuristic of pharmacology, the withdrawal process is the opposite of a drug process. So if a drug makes you feel really good in certain ways, the withdrawal process often makes you feel bad in a sort of opposite way. So what do opioids do? Well, opioids are analgesics, so they give you pain relief. So one of the withdrawal features that people don't talk about too much, because we always frame withdrawal in like the drug context, you know, as the person who like detoxes from heroin in the movie. And so maybe they weren't self-medicating a severe pain, but they still hurt, I promise. Right? Their joints hurt, their joints hurt, their bones hurt, their muscles hurt, everything hurts because they're hyperalgesic. But also, if you were self-medicating anything, that explodes, right? So my foot immediately explodes, everything in my body hurts. But what else do opioids do? So they're sedatives, right? So they're respiratory sedatives, that's why they can kill you. Eventually just stop breathing. They're digestive sedatives, so you have opioid receptors in your gut, that's why you get constipated. So when you take away the sedation effect, well, your gut goes crazy, so vomiting and diarrhea and all that terrible stuff. But also, you get this like weird hyperactivity. And so the only way I can explain it to you is it's like if you've ever had just a really uncomfortable level of caffeine, like think about those jitters, dial it up to 1,000 and it doesn't go away for weeks. And that's background, and it does a couple of things. So it makes you restless. So if you ever seen like in the movies, the jittery part of withdrawal, that's where the jitters come from. So your muscles feel like they need to twitch, and you've got this electric energy built up. So you feel like you have restless leg syndrome. This is where it comes like kicking the habit, right? The kicking, that's where that comes from. Fun fact. So the jitteriness, but it does something else too, because it keeps you awake. And so you sleep less and less. As your withdrawal gets worse, you sleep even less. And so all of these symptoms that torture you, you also have this like the worst sleep you can imagine times 1,000. All of that stuff is happening, but now it's happening like 20 hours a day, 22 hours a day, 23 hours a day. So you can't sleep. You can't rest, and you can't recover, and that makes the pain worse. But opioids do something else that we are very familiar with, right? They're euphorics. They make you feel great. They wrap you in a warm blanket. They give you a sense of joy and peace and contentment. So what's the opposite of that? Dysphoria. Crushing depression. So that's the experience of withdrawal. You can, of course, have mild, moderate, severe withdrawal. I would guess looking back that week 1 was like moderate. At the time, I thought I was going to die, but that's because I didn't know what was coming. So why does it get worse? Here's the like nasty joke of brain chemistry, cosmic injustice. So the severity of tapering does not track like a raw volume, like how many morphine milligrams you reduce, right? Because some people are on 1,000 morphine milligram equivalents. That's our standard unit measure. So just think like 1,000 milligrams of morphine, monster dose. And so if you drop 100, that's only 10%, right? So the raw volume doesn't matter nearly as much as the percentage dose reduction. So the severity of withdrawal tracks the percentage dose reduction. So here's the thing that I didn't know, and boy, I wish I knew it. That handy dandy tapering guide he gave me, 25% a week, was not 25% a week. It was 25% the first week. Because here's what happens. Brains are really sophisticated learning machines. They really want to be at homeostasis, right? They want to balance out, which is why you develop tolerance to the drug in the first place. So now you drop, so let's make the math easy. So you started with 100 milligrams of whatever. You dropped 25 because that was your quarter dose, right? So you went from 100 to 75, that was a 25% dose reduction. And now you wait a week and your brain is doing this job. So over the course of that week, and it turns out the withdrawal process is like 7 to 10 days, pretty much like clockwork. So really mean, because right about the 7-day period, my brain was reestablishing homeostasis. I was about to come out of this, and slowly, it depends on variation, nature's a bell curve, right? But on day 7, right about as my brain is getting used to 75 milligrams, I dropped 25 again. Now it's not 25 from 100, it's 25 from 75. That's a 33% dose drop. Y'all, I love it. I hear the understanding going, oh, that's really bad. Yeah. So week 2 is a 33% dose drop. What's week 3? A 50% dose drop. And at the end, it's 100. So people who work in addiction medicine, which I know at least have a couple in the room, have seen this a lot. People who have to go through a tapering regimen, either their drug of choice or methadone or buprenorphine, they make it so far and they're working so hard and they want it so bad, and then they fail to taper at the very end. And it's just because it just gets worse and worse and it's unrelenting. And the slower you do it to not make it miserable, the longer it takes, right? Okay. So here's how the story ends for me. Every week we have to decide whether we're going to keep on this brutal schedule. You might be thinking, why in the world would you keep on this brutal schedule? Because we couldn't find out any information to tell us differently. That nobody would tell us what withdrawal is supposed to do, like how long it's supposed to go. Nobody would tell us that there are medications that they could be using to mitigate the withdrawal symptoms, but also just like way simpler, they could have just slowed down, right? And resolved a bunch of it. I was a pretty routine case. I've been on opioids for 2 months. This happens all the time. Everyone who's getting in a car accident tonight, a bunch of them are going to be on opioids for 2 months, right? This is not super outlier medicine. So we kept sticking to it because we couldn't find anyone to help us. I had 12 people years later when I'm writing a book, I'd request my medical records and I'd see how many people wrote prescriptions for me. Most of them were NPs or PAs, right? Because the doctors, so nurse practitioners or physician assistants, because the doctors are very often not taking the time to do this, right? 12 different people at 3 different hospitals wrote opioid prescriptions for me. And we couldn't get a single one of them to help me. And when we ran out of them, we just called anyone, just opening up Google. We spent our days Googling doctors. And we called everyone, and there were 2 camps of doctors. Those that couldn't help us because they had no idea how to taper opioids, and those that wouldn't help us because boy, did they not want me in their waiting room. So we stuck to it, and we stuck to it for the following reason. Because I truly believed that if I went back on the medication, I'd be on it forever. I would never do this to myself again. I told that to Sadia. She knew that. This was common knowledge between us. And the only thing that changed was in week 4, several days after I had any opioids in my system at all. I hadn't slept in days. I spent a night, the whole night on the bathroom floor trying to vomit, but I hadn't eaten anything in I don't know how many days / weeks. And I started thinking, my 1.5-year-old baby girl is watching this. I'm depressed, so my brain is turned on me. And so I'm like, I'm never getting better. He couldn't convince me otherwise. I'm a burden on my wife. So I think it's probably time to take care of this. Just check out, make it easier for everybody. And the morning finally comes, and I tell Sadie what happened, and we talk, and I finally tell her what I was thinking, and she said, I think it's time to go back in the meds. So that was the plan. So we called my prescribing doctor back, told him the plan. He said, thank God, because he'd been trying to get me to go back in the meds forever. He was scared and didn't know what was going to happen. A bunch of doctors, including him, told me to go to the emergency room. I said, what would they do at the emergency room? He said, put you on morphine. And so he prescribed the bottle. We asked for 5 milligram tablets of oxycodone so that I could do my own dosing. And I actually went to bed that night. So I went to bed for the first time in weeks. I'd been staying on the couch because I couldn't move. And I took a glass of water, more appropriately, Sadia put a glass of water on the nightstand and a bottle of oxycodone. And the plan was, I'm really stubborn. This is just a fact about me. And I couldn't stand the fact that I was just going to lie down and take a bunch of pills and get to sleep. So I like to torture myself, apparently. And so I said, you know what? If I still haven't slept in 4 hours, I'll take one. And if that doesn't put me to sleep, an hour later, I'll take another. And an hour later, I'll take another. And eventually I'll get to sleep. And that's my new starting dose. And then I just fell asleep before I took any. It was day 7. And I was exhausted, hadn't slept in days, the clock ran out, and I fell asleep within an hour, probably. And I slept for 6 hours that night, which was literally the first time in 4 weeks that had happened. So I made it out, sheer dumb luck. I woke up the next morning, I did not feel great, but I was hungry for the first time in a month, and the symptoms had receded rather than getting worse. And so I knew, I'm done, I can make this, the rest of this piece of cake. So, for like a month, maybe 2, I don't know, time. I was just really, really grateful, glad to be alive, glad to want to be alive, enjoying time with my family, really not wanting to think about any of that. But we just kept talking about it. It's like haunting. And so we eventually started telling people, here's an interesting fact we hadn't told anyone. I was a professor at Johns Hopkins. My people knew people. I had a PhD, my wife has a PhD. Presumably, we had more access than almost anyone on the planet to good health. We didn't even ask. And I wouldn't have identified the reason at the time, but it's got to be stigma. It's got to be shame. I didn't think there was anything wrong with what happened to me or what I did, but I clearly did, because I didn't want anyone to know about it. My colleagues all had seen the x-ray of my exploding foot, right? But no one knew about the withdrawal. We slowly started telling people. And a few people in a row, dear friends and family, would listen really compassionately, be angry on our behalf, and then say things like, gee, Travis, you're a bioethicist. Do you think you might have anything to say about this whole thing? And so then I started to itch, right? And this was the question for me, right? So I had this like very visceral question. The visceral question was all the privilege in the world, and I fell through the cracks. This happened to me. What the hell happens to everybody else? I was meeting with a group of folks earlier, like, we know what happens to everyone else, right? So that starts to eat at me. But I kept thinking I'm an N of 1, right? Scientists say N of 1, like I'm a single case. What does that teach us about anything? So the question that came to consume me as like a researcher is, are there actually any generalizable lessons from my experience? So that's how I started diving into this. P.S. I didn't know anything about medicine prior to this. I'm a bioethicist, but I worked on like climate change. I worked on animal agriculture, planetary limit stuff. This was not my world at all. So I just stopped everything else I was doing, went back to work and started learning as much addiction medicine, pain medicine, basic pharmacology, epidemiology of the drug overdose crisis. I wanted to know how in the world this happens. And I found a bunch of answers, like pretty easily too, kind of crazy. Like they were out there waiting to be found. So here was the first lesson. So this is from that same paper I published in 2017. the N of one problem, like that I'm only a single case study, I kept thinking like, what if I just got unlucky? But now go back to the basic point. DC, Baltimore, world-class hospitals that rebuilt my foot out of my thigh. Professor married to a PhD, and we fell through the cracks. Like nobody should get this unlucky, but if I did, other people are too, right? So this was the first thing that I started thinking about. And so I started thinking about clinicians letting this happen. So the very short payoff of that first piece that I wrote in Health Affairs was just clinicians don't prescribe a drug that you don't know how to control. Like if you're giving the on-ramp, someone's got to give the off-ramp, right? Seemed like the most obvious thing I've ever argued for, ever. But it clearly needed to be said because I published it and everybody's like, oh, you should come say that in front of our hospital. Okay, seems kind of obvious, but okay. So I was worried about physicians letting this happen. But then I kept reading. And some crazy stuff was happening in pain medicine. I've already spoken to a few of you earlier tonight, and I know that at least some people in this room are very aware of this. I didn't know anything about this in 2017. Whoops, I turned it off. Sometimes clinicians actually do it. And what I mean by that is not like, look, a lot of times clinicians did the prescribing and then can't taper. So there's a sense in which they did it. But they were just trying to be good doctors. They were trying to take care of their patients' pain. By and large here, I work with physicians, I train med students, I train residents. They're good people who want to help other people. And they were super excited when the country said, hey, guess what? Opioids are great again. You can give them to all your patients. That was great news because now you have a safe and effective therapy that gets your patients out of pain. If you want to help your patients, that's awesome. But there's this other thing happening out there. My case was routine on opioids for a couple months, the sort of thing that happens when people are in accidents. But because we've been prescribing these opioids for a couple decades now, more, right? Starting in about 1995, 96, you get the uptake. I'm going to show you a graph later. But we really fell in love with opioids as a country/continent, North America as a whole. A bunch of Canadians in the room. Canada's opioid crisis is just like 3 years behind ours, right? It's like 1995, 96, and really blossoming over the 2000s. What that means is that there are a bunch of pain patients who are given opioids with no evidence base, by the way. It's like low back pain, here, OxyContin. Like we have good evidence now that that was never a good use, but opioids have tolerance as an issue to be dealt with. And so their prescription kept getting escalated because they were told by pharma that there's no ceiling. You can just keep giving more. So now we have a population of patients who were started on opioids in the 90s and the early 2000s and were escalated for years or decades. They're on massive, massive doses. But what's changed in the meantime? Now we're scared of opioids. They started killing tens of thousands of people. Tom Frieden in 2008, I think, the then director of the CDC, looked at the medical establishment and said, the prescription opioid crisis is doctor-driven, right? Doctors should solve it. And so instead of being med school, like, hey, you really have to take care of your patient's pain. Pain is the fifth vital sign. I don't know if you've heard of that. Like, we have to treat all the pain, right? Now it's like, oh God, opioids are killing people. Don't use opioids. Every year I ask my med students at Johns Hopkins School of Medicine, not a shabby little school. I ask them every year, what have you learned so far in M1 about opioids? And they're like, don't use them. They're bad. Definitely don't use them for chronic pain. Good Lord, I keep pressing the off button. Okay. So I know you won't be able to read this text. I'm going to read a couple things to you. Sorry for Zoom, folks. It's going to look like I'm just talking right into you. Okay. So this is a story that was in Stat Magazine about a really cool guy, a very, very good compassionate doc named Stefan Kertész. And Stefan discovered this population of patients, and so they're often called legacy patients. They're patients who are a legacy of this past aggressive opioid prescribing patterns. But now we're scared of opioids. So what's happening to them? Well, he started hearing because people would come to him. He's a VA doc, so he'd get VA vets coming to him and being cut off from their opioids. Sometimes there are folks who their longtime doctor died or retired. And now they go to someone else like, hey, here's my prescription. And they're like 800 morphine milligram equivalents. No, that is absolutely not going to happen. I'm not going to write that prescription. That's not going to show up on my DEA license. right? So Stefan got really interested in this. So this little box is describing him, and it says, he grew concerned by the medical community's efforts to regain control over prescribing patterns after years of lax distribution. Limiting prescriptions for new patients had clear benefits, he thought, but he wondered about the results of reductions among legacy patients. Their outcomes weren't being tracked. So we started tracking them. He's got a big grant right now. He's actually trying to pull together some data because we don't have data on this population, but we're hearing anecdotes. And some of them are really awful. Some of these patients are going to the black market. And so they're finding heroin, or it's more common now, fentanyl, to self-medicate. And some of them are committing suicide. So we now have documented reports of people committing suicide from pain and withdrawal. So this is a piece from the New England Journal. The lead author, Debbie Dow, was the lead author of the 2016 opioid guidelines from the CDC. So this is someone who is on the front lines telling people, like, here's how to carefully and responsibly use opioids. But she and her team wanted to admit really loudly, like, no, our guidelines have been abused. They've been misused and misapplied. So here's what she says at the bottom of this page here. Efforts to implement prescribing recommendations to reduce opioid-related harms are laudable. Unfortunately, some policies and practices purportedly derived from the guideline have in fact been inconsistent with and often go beyond its recommendations. So consensus panel has highlighted them. These include inflexible application of recommended dosage and duration thresholds. So people are like, oh, the CDC says don't give more than 3 or 7 days of opioids, so I can't do that for you, even if this patient's been on opioids for 17 years, right? Or the CDC says no more than 90 morphine milligram equivalents. This patient's on 900. That's not who they were written for. They were written for new patients escalating. So she said these inflexible application encourage hard limits and abrupt tapering of drug dosages, resulting in sudden opioid discontinuation or dismissal of patients from a physician's practice. So the CDC, the lead authors of the guidelines, are actually noticing this too. The FDA has now acknowledged that they have seen the reports of suicide, and they're telling doctors, don't abandon your patients, don't abruptly discontinue. And the HHS itself has put out a guideline that says explicitly, do not abandon or abruptly discontinue opioids for your patients. But we're going to get to some of these cases, and some of you who actually do the work know some of these cases where it feels really, really problematic to continue writing these prescriptions when the world is telling you don't write prescriptions for lethal doses of opioids. So I'm not going to talk a bunch about this now, but I'm flagging it. Some cards on the table. You're welcome to ask me about it later. This is a paper I published last year, and I made a very controversial argument in the medical. So this is the American Medical Association's Journal of Ethics. And the argument that I made was that non-consensual dose reduction for patients who are stable is ethically impermissible. And what this means is that you must get patients buy-in before you start tapering them. And so if they're never ready, well, that's a hard case, but you still don't get to unilaterally taper them. This doesn't deal with patients who clearly have a use disorder, but for stable patients who have been a steady dose for a very long time, it's not interfering with their life. It's a harm expanding rather than a harm reducing intervention to destabilize them when we know some of the bad outcomes. You have to partner with your patients, says the argument. Okay. Why are we in this sort of trouble? So my case is this like routine dependence and routine withdrawal case. Somebody should have a hand at it, but they're much harder cases, these legacy patients. One of the things that took me like 3 years to recognize is I think a big part of the problem is that we, society, people, but including the medical establishment often, don't know the difference between physical dependence and addiction. So some of you in this room are going to say, oh, I don't know what the difference is. Okay, I'm going to show you. It's super clear, but it might also just kind of blow your mind. One of these days, I'm going to press the right button the first try. All right, so what are the characteristics of physical dependence versus addiction? So physical dependence is when you have withdrawal after sudden discontinuation or abrupt tapering. This is just how brains work. So in this room and the virtual room, 100% of you will experience withdrawal if we give you a high enough dose around the clock long enough. That's just how brains work. Remember the whole trying to reestablish homeostasis thing? You put a bunch of exogenous opioids, so not from your body, from the world, into your central nervous system. And your central nervous system, the first time goes, oh, that's amazing, but it really doesn't like being destabilized. So it tries to react less aggressively every time. And that's why you need more every time. And then it gets used to this exogenous flood. And if you take it away, you get super sick because your body's not doing the work anymore. So we have endogenous opioids. If you never knew this, endorphins, endogenous morphine. That's why it's called that way, right? Cool stuff. Okay. Occurs in 100% of people who are on high enough dose, long enough around the clock. So what's addiction? Addiction is something very different. It's a behavioral health problem. It comes with cravings. Paradigmatically, it's somebody who wants the drug. Now, there are two kinds of cravings. It gets complicated because if you want to avoid withdrawal, you can have aversive cravings. So I crave the drugs that would rescue me from withdrawal. But that's not actually the most powerful form of craving for a lot of drugs. For opioids, it's really powerful because the withdrawal is terrible. Benzos too, alcohol too. Cocaine, withdrawal is not that bad. The high is amazing. I'm not giving you a sales job, but like really, really euphoric drug. So the craving for cocaine is usually a pull. And then drugs like heroin and fentanyl and oxycodone, like these opioids, they have the pull of euphoria and the push of withdrawal. Here's the main characteristic: continued use despite negative consequences. That's the thing. You want to know whether or not something's an addiction? Ask whether that's happening. So is somebody hurting themselves, hurting other people, getting into trouble with their behavior? If the answer is yes, we start thinking about this diagnostic model, right? But a bunch of people are physically dependent on a lot of substances. I'm going to show you some of them in a minute. The other thing about addiction, it occurs in the vast minority of people exposed to a drug. How vast? We don't know. It's really hard to track. Not sure. There's a bunch of meta reviews out there, but there's somewhere between 1 and 11% of people exposed to an opioid develop an addiction. And so like the most common number cited is 6%. So really, really small. Now, population wise, if you give 100 million people opioids, 6% is a problem, right? But it's real different from dependence, which occurs in everyone. All right, so just think about some different cases. If you lose track of this distinction later, but you're a nerd like me, you like really want to know this is a factoid. There are a bunch of drugs that a bunch of us take that cause dependence and no addiction. Psych meds, a ton of the psych meds do this, right? So if you've ever been on an SSRI, SSRIs are almost anti-addictive because they front load the side effects and backload the benefits. So there's no euphoria. Nobody takes Lexapro to get high, right? Nobody takes Prozac to get high. But they cause physical dependence. Your central nervous system makes this adjustment. So if anyone's ever gone on an SSRI and then just stopped cold turkey, it's miserable. Those drugs cause dependence, but they are not addictive. Lots of other psych meds do this. There are some heart medications that do this, right? There are a whole bunch of things that nobody has ever thought, oh man, I hope I'm not addicted to my heart medication. Because it's just a problem of making you sick. You're not going to have cravings. It's not going to lead you to lose your marriage and lose your house and pursue everything for this one goal, this one good. There are some things that are addictive that do not cause dependence, like gambling. Super euphoric, but it's all coming from outside the world. You do not have your kind of natives like an opioid case. You have an opioid system, right? That gets accustomed to it. So when you pull it away, you get withdrawal. That's not what happens in gambling. Gambling is just engaging with the brain's reward system, and that's the thing that works in addiction, right? And then there are a bunch of things that do them both, right? So opioids are in this class, benzodiazepines are in this class. Alcohol is in this class, although fewer people who have an addiction to alcohol get a simultaneous dependence. You have to drink so consistently, right? So if you're a binge alcoholic, you may not be dependent. Cocaine has some dependence, but really minor compared to the other ones. Like benzos and alcohol, withdrawal can kill you. Opioids can make you want to die, but the only people who I know of who have ever died from opioid withdrawal die of dehydration, vomiting and diarrhea in a jail cell, usually. So the ones in the middle that are addictive and can cause physical dependence, they really get at us from both sides, right? But when we understand this, we recognize that there are these two different problems, right? So one of the questions we should ask is like, whose job is dependence care? Because I've heard of addiction medicine. I haven't heard of dependence medicine. And boy, did I look for it for about 4 weeks, it turns out. So I tried to figure out whose responsibility was routine dependence care in my case. So I went to all my prescribers and they said, not it. So I said, whose job is it? And they said, well, this is a complex pain case. You need pain management. So I went to pain management and my pain management team from the hospital said, oh, we're an inpatient team. We don't deal with tapering or withdrawal management. And I thought that was absolutely insane. But we called an independent pain management team, not affiliated with the hospital, so they couldn't give us the inpatient excuse. But they still said basically the same thing. They said, we can prescribe more opioids if you run out. Like we can evaluate you if what you need is more opioids, but we don't deal with withdrawal management. We don't deal with tapering. And I was so frustrated at this point, and I was almost certainly crying. I cried a lot during these days. And I said, whose job am I if I'm not yours? So I don't know, addiction medicine? Okay, so here's where I think that mistake was happening. They hear dependence, they hear withdrawal, and they think addiction, because we run them together in society. When you think of addiction, who do you think of? Think of like the shaky, sweaty, nauseous person, right? So I'm like, fine. I didn't actually think I had an addiction. It hadn't really occurred to me. I was sick and I was trying to solve that problem, but if addiction medicine was gonna help me, then sign me up. So I start calling. The first place I called, I would find out later. I would figure out all my mistakes later, right? But it turns out they called a methadone clinic. But I was just like Googling rehab, you know, like addiction, detox, rehab, like, and so I called what turns out to be a methadone clinic. And I will never forget this very short conversation, a very sweet woman who listened to my story. She was probably very busy and didn't have time to listen to my story, but she did. And she said, oh, honey, you are not our problem. And I said, whose problem am I? So I don't know, you're a prescriber? That's about the time I gave up. So, lesson 1. I was looking for generalizable lessons. That was a while ago, maybe you forgot. I was looking for generalizable lessons. So lesson 1. Stopping a medication is morally different from not starting it. And so this matters because as we start to get afraid of opioids, good Lord, I gave away all my secrets. Okay. As we start to get afraid of opioids in this country, we try to reduce the number of opioids going out in the world. And when it's called for, when they weren't needed, when we sent out bottles of 60 Vicodin for a routine wisdom tooth extraction for a 12-year-old, right? Absolutely a good idea to reduce the numbers going out there. But not starting somebody on opioids is real different from not giving them opioids when they're physically dependent. And we got a lot of those people coming into the hospitals and doctor's offices these days. Lesson number 2 is stopping the medication has to be someone's job. And my first go at this, I said, the doctor who does the actual prescription. I think I was kind of thinking of like an outpatient family doc who's prescribed a ton of opioids. So from the years like post 2000 to 2012 or so, the highest volume prescribers were family practitioners, right? So the folks who just had a lot of patients coming in, low back pain, especially in places like Appalachia. So a lot of folks doing really strenuous work. And so doing a lot of actual prescribing. I was like, well, look, you're the one who writes the prescription. You're the doc. It's on you. And I realized as I started talking to like surgical hospitals, I started consulting for a hospital for special surgery in New York. And they're like, look, you're right about the gap. You're right about a bunch of stuff. But our orthopedic surgeons are not going to do like tapering follow-up. We've got to find a solution. We've got to find a structural solution. So maybe it's a team of nurse practitioners, right? You train them up and they do everybody's tapering after big orthopedic surgeries. It's a lot of these surgeries, they're going to be on opioids for 2-3 weeks. That's enough, by the way, in case you're wondering like how long does it take to develop dependence. You won't have it like me, but 2-3 weeks, you're going to get sick if you just stop. Okay, so it has to be someone's job. Lesson number 3. The job isn't always treating addiction. It might be, because a whole bunch of people have an addiction. If they're addicted to opioids, they're also gonna have physical dependence because they're shooting heroin several times a day. But a bunch of people are just dependent. They need a different set of resources, which is really good because the addiction medicine infrastructure in this country is hopelessly overwhelmed. And they can't take it. Remember that really kind woman who said, you are not our job? Part of her reaction was, she said something like, we have a waiting list, and the people on the waiting list are going to go buy heroin laced with fentanyl and might die with their next shot. And you just can't stop your pills without throwing up. It's like, different job here, right? So they could go together, but they need not, and we need an infrastructure. Okay, check my time. So I'm an ethicist. One of the things that I want to do is I want to look at health policy, I want to look at medical practice, and I want to try to figure out, like, what do we need to correct? I mean, sometimes I get invited to just go talk to doctors and like, here's how you need to think about prescribing. But a lot of times, like, we're all patients at some point, right? And we're all members of a society, and we need to have a view about the appropriate use of certain drugs. And that view is being dominated by a really simplistic narrative. For a long time, the narrative was opioids are evil. By the way, there's an interesting history that explains that. It's because we had an opioid overdose crisis at the turn of the last century, 1800s to 1900s. Thanks to morphine and heroin, we got all scared of opioids. It lasted for almost a century. Then we went all in on opioids. Thanks Purdue Pharma, thanks Insys Therapeutics, right? We have a bunch of drugs that kind of became a stand-in for opioids are safe and effective, and you should give them to all of your pain patients. And we're all in. So here's the graph I promised you was coming. What I'm going to try to do is I'm going to try to explain this graph in a way that helps us understand the cultural moment of how we think about drugs. So this is showing the overdose death rates by class of opioids, right? So the one that goes up first is from 1999 to 2018. We have 2019 data now, but I submitted my slides for CME, so I didn't change them. And we have preliminary 2020 data that I can tell you if you want. The bluish line that goes up first is the overdose death rate from semi-synthetic opioids, which are commonly prescribed opioids. So this class is basically oxycodone, hydrocodone. So brand names, this is your Vicodin and Percocet. It's OxyContin, right, which is just an extended release version of oxycodone. This is everything commonly prescribed except fentanyl, because fentanyl is used relatively little in medicine and is everywhere in the illicit drug supply. So it's separate, it's a fully synthetic drug. So the overdose death rate from commonly prescribed opioids between 1999 and the peak, which occurs in about 2012, 11, quadruples. Goes up 400%. What happens during that exact same time? The volume of opioids that we prescribe quadruples. Goes up exactly 400%. So we have a lockstep climbing of our increase in supply and the drug overdose death rate from precisely those drugs. That's why we got scared, because the epidemiologists started pulling this together in the second half of the first decade of the century, 2007, 2008, 2009. So then we start yelling at doctors and saying, you're causing the problem, stop killing your patients. And we start trying to slam that door shut. And we succeed. We finally bend the curve on prescribing in about 2011, 2012. So what happens? For a minute, the overdose death rate does actually go down. So we solved this very precisely named problem of prescription opioid overdose. But what else happens at that moment? Well, the green line that starts shooting up around then, that's overdose death rates from heroin. It flips. So what happens if somebody has an addiction, which now remember is characterized by willingness to continue a behavior despite negative consequences? So we take away a bunch of people's clean pharmaceutical grade regulated drug supply, and we know that some of them that has the use disorder that we're worried about trying to fight is going to act even if there's a threat. So maybe like be willing to go to the black market to get their fix. And now we are awash in heroin. So there's a separate interesting story about how heroin got here. I've got a good book recommendation for you if you want to read that, but it's everywhere and it's dirt cheap. So a bunch of people switched to heroin. In the years shortly following this, we finally get some data that shows 75% of the people who started on opioids after 2000 started with prescription opioids, but almost all of them are taking heroin. So it's very cheap, it's everywhere, and prescriptions are being cut off. Now there's something called the Iron Law Prohibition, which says when you start to really concentrate law enforcement on a product, the people who are selling that product are going to make it more dangerous because they're going to make it denser, smaller, easier to package, easier to get around, evade law enforcement. And so what starts to happen when all of this attention starts to get paid to heroin is drug dealers discover fentanyl and fentanyl analogs. So if you don't know what fentanyl is, it's 50 to 100 times more potent than morphine. So really serious med. But it has all of these chemical analogs because we didn't discover this. This didn't come from the poppy plant. You know, heroin was cooked morphine basically, and morphine came from the poppy plant. This was made in a lab and it's cheap. And you don't have to have much chemistry education to do it. Fully synthetic drug, and all of the analogs, the chemicals have just like one little change. Some of them are even more potent. So there's one called carfentanil. It's 10,000 times more potent than morphine. It was found in the drug supply in Baltimore. It's been found in the drug supply in Vancouver. We use it as an elephant tranquilizer, and it's showing up in our drug supply. And that is the overdose death rate that's shooting through the roof. So this is our landscape. And what I want you to take away from this is we have ping-ponged back and forth between being afraid of opioids and embracing them as a medical solution. But when we are afraid of opioids and we try to clamp down on them, we cannot solve the problem with that clamping down because we push people to illicit supplies, which are more dangerous than the prescription ones. That you might be wondering, well, what the heck do we do? That doesn't mean just give drugs to everybody. Like that's a hard policy question. But what it does mean is when you just take away a supply from somebody, it's a harm expanding intervention, not a harm reducing one. Okay, so here's just like the least helpful graph you'll ever see. So what's our attitude towards opioids look like? I mean, we could be restrictionist. We worked through most of the 20th century. Opioids are bad, don't use them. Or we could be like, hey, drugs for everybody. We were that way for, 15, 20 years almost. And we just can't settle anywhere in the middle. And that's where we need to be. See, I told you, like super helpless graph, right? Like, hey, you gotta be somewhere in the middle, guys. All right, so my closing remarks, I'm gonna try to say what that might look like. What does it look like to have something like a responsible view towards using opioids? And that means sitting in the middle and not just saying they're bad or they're good. Because here's the truth about opioids, they're just drugs. What are drugs? They're the things we develop with science that have good and bad effects. They have on-target effects, the thing that helps bodies, and then they have a bunch of side effects, the things that make us sick. This is just the first rule of pharmacology. Okay, so what does it look like to try to live somewhere here in the middle? Travis Rieder's patent pending, tripartite principle for responsible prescribing. Now, for those of you who are prescribers, like this is for you, but for non-prescribers, like this is the attitude I want us all to have, like our doctors owe us this, right? So we do want doctors only to initiate opioids when appropriate. This is the one that gets all the play, but it's not everything because they also have to manage the opioids. And then, I'm like pretty partial to this one. They have to discontinue them appropriately. All of the intention has been on the first one and we've still sucked at it. So all the headlines are, we fixed the opioid crisis by like cutting people off from their opioids. That's not appropriate initiation. Appropriate initiation is using them when the balance of benefits to risks turn out okay. Because it turns out they have benefits, severe pain relief. Ask me about when my foot was blown open, if I wanted that morphine or fentanyl. Yes. But we also have to do it in a just way. Because when we're trying to reduce our opioid use, we don't do it in an egalitarian way. Some groups get more than others. I'll bet you can think of who the groups are. We have a ton of data on this, right? Someone who looks approximately like me gets most of the opioids prescribed, right? If you're a woman, so this is all data, it's not editorializing. We've got loads of research on this. If you're a woman, your pain is going to be taken less seriously because women are hysterical. And we're going to prescribe fewer opioids for you. Like this is a long misogynistic history, right? If you are a person of color, you are going to be judged to be a drug seeker, taking your pain to be faking it or malingering more often, and therefore have opioids prescribed at a lesser rate. So it can't just be that we reduce it when it's appropriate. We have to do it in an egalitarian way, that we're not taking like race and gender as a reason to prescribe or not. The management is probably pretty self-explanatory, but we're not doing it because we treated opioids for a long time like they were antibiotics, prescribe and forget, right? You don't have to have any specialty training, was the view. No one got taught opioids. There was a survey that Johns Hopkins did of medical schools. Over half of the medical schools in the US didn't require any pain medication education. The average number of hours was between 4 and 11. Canadian trained veterinarians got more, they got about 89. So prescribe and forget doesn't work because you have to do this regular check-in, probably behavioral health assessments. You've got to be looking for the signs of misuse and developing use disorder, but also dependence, right? And there's gonna be a lot of understanding checking because sometimes your patient, even if they look like they might be kind of well-informed, like a professor at Johns Hopkins, doesn't know anything about opioids and will not plan for the future. Finally, you know, I've got views on this one, appropriate discontinuation. So here is my friend, David Sherlink. Canadians get lots of play tonight. He's a Toronto-based toxicologist and physician. When he does his training, he uses my story as a case study. He tells his residents and his fellows this: don't fly a plane if you don't know how to land. That's the whole story. That could have been the talk. There you go. Don't fly a plane if you don't know how to land. I'm not going to talk through this, but this is literally how hard it is to learn how to taper. So I worked as a consultant with this group called the Atom Alliance. We spent a few weeks making sure we had the data right, doing some expert evaluation. This is like a bookmark, front and back. And that's enough knowledge to do routine withdrawal management. Now, the legacy patients are not routine. They require a different level of expertise. But that amount of information that fits on half of a slide could have saved me a world of hurt. And we don't train our med students. Someone does. Most people don't. So there's the tripartite principle of responsible prescribing. If you're a prescriber, I hope that lands with you. But if you're not a prescriber, I hope you feel entitled to that from physicians, because that's what they owe you. So opioids are really complex drugs. We've pretended like they're not, but they are. And so the ethics of using them is pretty tough too. Thanks so much. Really appreciate it. I think I'm supposed to take questions, which I'm very happy to do. I don't know if anyone wants to moderate, but.
There it goes. Okay, so yes, thank you. If there are questions online, if you want to type them into the chat, and Cicely will let us know what those questions are. But anyone in the room have a question?
I'm Steve Williams. I'm head of the anesthesia group here in town. And great talk. I probably have 1,000 questions and 5,000 comments. So it's hard to narrow it down to one question. We do a lot of nerve blocks for our patients here in town. So we're attacking the problem as best we can by limiting, not eliminating, but eliminating the amount of opioids that we prescribe in the perioperative area. And this community should be proud that we lead the country as measured by Aspire, a Blue Cross Blue Shield of Michigan collaborative with anesthesia that includes hospitals like Yale, like UCLA, like University of Michigan. But our hospital leads the country in the reduced amount of opioids that we have in the perioperative period, because 80% of our patients get nerve blocks. Okay, so my question is, for those patients that come in that are already prescribed narcotics, despite doing nerve blocks, we still have to deal with this issue.
Yeah.
And so what it's hard to do from a practitioner standpoint is go to the escalated doses that they're on when they're in the hospital and maintain that when it just doesn't feel right. So I was wondering if you might make a comment about that.
Oh my God, yeah. So start out with an easy one. Yeah, so nerve blocks are a huge help. And so very often when I give a talk to anesthesiologists, like the first 3 questions are, why didn't you get a nerve block? I didn't give you a nerve block. You would have done a lot better if I did a nerve block. And so of course my case is different. I had trauma. So they worried about crushed leg, right? Crushed compartment syndrome. Thank you. So the explanation I got later is they were worried about compartment syndrome. So if you don't know, kind of the only way you usually identify compartment syndrome in a crush injury is like wildly out of range pain. And so if you block somebody who has a crush injury, they could develop compartment syndrome. You don't know because they don't have any feeling, and then you end up losing the leg. So that was the explanation I got given later on. But of course, for a lot of routine surgeries, nerve blocks are helping a lot. Your question though is about this really hard group that comes in already on opioids. So there are two different things we should say. So at Hopkins, we started an outpatient tapering clinic that preps people for surgery. So in non-emergent cases, we have this group, and they're pretty much their entire job is dependence management. But the majority of it was done for the sake of these complex patients who need to have surgery. And so if you're planning a surgery, if it's something that's elective or semi-elective and you've got time for this, what they really try to do is get them down to a dose that they're at least more comfortable with before the surgery. So it doesn't work in emergency cases, obviously. I'm going to give an answer that might be really unpopular with you and your group, but I think it's the only one I got, and we just have to keep talking about it. You can't reduce them when that's not your job, right? And so if they come in, make up numbers, if they come in on 400 MMEs and you're going to block them, so you're not going to cause them any more pain. Well, giving them anything less than 400 is going to give them pain, right? It's just not in the place that you blocked them. And so it feels weird, it feels icky. But what else could we possibly do that's responsible, right? Like you're introducing suffering for a patient. So I think that's the only answer I can give. But we could probably spend time like really dialing in on cases and seeing what we could do to try to be as responsible as possible. But I think my general principle would be you can't introduce suffering by like forcing the patient to withdraw, basically. Start off with the easy one. Anybody else want to follow?
Any other questions? Cicely, is the one online?
I don't actually have a question, but I briefly, I have a cadre of patients that I inherited who are on pretty high doses of opioids, and I still maintain them. And I have to write all my own prescriptions to use their records, and that's cleaner. And I know it makes people uncomfortable, not what I wanted to do, but I love what you're saying because it's what I've been talking about forever. I just didn't
Now you know. You're a doctor, you don't have to write a book. Yeah. So I will say, so one, I'm really grateful to you. So when you write a book like this, when you give a TED talk like this, like one of my full-time jobs is getting email from patients who are suffering, right? I'm pretty easy to find online. And so I get emails just constantly from patients in active withdrawal, who've been abandoned by their physician, who can't find someone to take care of them. And I'm just really grateful that there are folks who are still taking them on. I had a conversation recently with a doc who's got quite a bit of experience with tapering in a partnered way, some of these legacy patients on really high doses. And he gave me a spiel that was so compelling when he said it. And so he just is a very warm person, and his compassion is very clear. And so one of the things he says is every time he meets with a patient who's on maintenance on these really high doses, he has a new kind of motivational interview, right? We try to get them to aim towards new habits that he thinks are healthier. If you can get the dose down from 1,000 to 200 is great, right? 200 is still above the CDC line, but there's less risk with 200 MMEs out there than with 1,000 MMEs out there for both the patient and kids and neighbors and people coming around, right? But he also just gave the litany of possible benefits of tapering. So one thing I didn't go into here is that there are lots of possible benefits of getting off opioids, because opioids are kind of nasty drugs, right? They like affect your life negatively in all sorts of ways. And if you've been on them for 16 years, you may not know that you would feel all things considered better if you got off of them. And so getting somebody to come around to trial with you and know that they're going to be supported the whole way and you're going to have their back is a big part of the battle, I think.
Yeah, we talk about the walk with.
Yes.
Well, that's the place we get support.
Yeah, because they may not want you to hold their hand, but want you to walk with you. Yeah, that's great.
There was a, sorry, there was a brief question from Zoom. Jennifer asks, you mentioned a book recommendation during your lecture?
Yes, so that was for if you want to understand how heroin got here in the way it is today. There's been heroin in the country since heroin was invented in 1898, well, patented anyway. But the way it took over the country was totally fascinating. It came in from Mexico rather than Colombia, where a lot of the white powder heroin had been coming, and the Mexican black tar heroin, which was totally different. Nobody knew where it came from for a very long time in the early 2000s. It was coming from the West rather than the East Coast. And so this journalist, Sam Quinones, spent years of his life trying to figure out where in the world all this cheap, reliable, potent heroin is coming from. And he figured it out. It was literally all coming from this one little town in Mexico, from this family, he calls the Jalisco Boys because the town is Jalisco. And they're just like really friendly drug dealers. They don't carry guns. They responded to beeper calls, and this is pre-cell phones. And so you get the number and you beep them, and they deliver it to your house with no guns, smiling. And if they got caught, they just got deported. They didn't get sent to jail. And then 2 more would come to fill their place. And the country got saturated in cheap, potent heroin. It's also harder to mix black tar than it is the like white powder cocaine or white powder heroin. So the book is Sam Quinones is the journalist who discovered it, and the book is called Dreamland, and it's incredible. Yeah, it is rightly earned accolades.
I just wanted to add the concept of patient advocacy for themselves too. I know we're talking a lot about providers here, but from my perspective, patient advocacy is a key piece here in taking control of your own treatment and making them use some other things too.
Totally, so it's why I talk to lots of different kinds of audiences, because the prescribers, I want them to endorse these principles, but the patients, I want them to demand adherence to those principles, right? I'm owed a certain level of responsibility with this medication. I don't want the patients to have to do that. I want the healthcare system to be healthy enough that you get that whether you know it or not. But sometimes you have to advocate. Yeah.
Any other questions?
Yeah.
What does advocating, like if you know you're gonna have a surgery or something like that, what are the points to do that?
Yeah, so it's a really good question. So I like both the question you should be asking, but also like if you're at the intersection of gender and race. So it's easy for me to advocate, right? Because when I ask physicians for things, they don't call me uppity and they don't assume that I'm a drug seeker, right? So that's part of the reason I want the pressure to be on prescribers, because I want you to get care without having to demand it. But for questions, I think what you basically want to know is, I hear from a lot of people, I think I even heard from a couple of people tonight kind of throughout the day as I was having some meetings, people saying, I don't even want opioids anymore. Like if it's a minor surgery and they tell me I can get away with ibuprofen, like that's my plan. Part of what I want is I want patients to feel empowered to ask what the pain experience is actually going to be like, because doctors like to, some doctors, I'm sure present company excluded, but some doctors like to do what's called hanging crypt, right? Like they try to like give a view of what things are like and how hard it actually is. I think you are entitled to know like how much suffering is reasonable to expect, and then what the pros and cons of various therapies are. And we've gotten good at some of it, right? So it's not like we can't do this, because if you have liver problems, they're going to tell you not to take Tylenol, right? Like if you have gastro problems, they're going to tell you not to take ibuprofen. Like we know that some painkiller side effects are serious enough that they're contraindicated in these ways. But because of the stigma around opioids, it's just way easier to just be like, oh, don't take those unless you have to. And then if you have to, if your foot blown apart, you just, well, obviously you need them and just give them to you, right? But what every patient deserves, the one with the minor injury, minor surgery, and the one with the trauma, is they deserve to know, like, do you really need it? The answer might be like, some people do, some people don't. Laparoscopic gallbladder surgery. Some people are just like ibuprofen, tea, rest, fine. Some people take 12 pills over 3 days. Some people take like 3. And that's a totally reasonable response. You know why? Because pain sucks. And if you've had somebody cut into you, and it's going to mean that you can actually sleep for 2 nights and let your body do the work of healing, it's not a crazy thing to expect a potent painkiller for 2 nights of decent rest. If you have a knee replacement or hip replacement, these are intensely painful surgeries, but they also require rehab, right? So not only are they going to do, if you've never thought about what a knee replacement is, like only if you're not queasy, look at pictures online, it's carpentry, right? Like it's hammers and stuff. So like it's a hugely painful surgery. So we now have an evidence base for a bunch of our opioid prescribing. And it's one of the routine procedures that gets the kind of the grace for most doses. Like, so people are talking about Michigan, so University of Michigan has a bunch of great evidence-based guidelines now. And knee replacements and hip replacements are 2 of the surgeries that you should feel kind of like permissibly authorized to give pretty solid doses of opioids for. But partially it's because you need to exercise as soon as you start recovering, right? And so now what does the doctor need to tell you? They need to tell you, A, look, even if you don't like painkillers, you might need this to make yourself do the PT. But B, don't medicate yourself into oblivion because you have to know when to stop, right? If you medicate yourself into oblivion and then you try to do your PT, you can't feel it, you're going to do something bad to yourself, right? Like this is really nuanced stuff and it takes a little bit of time and our healthcare system does not incentivize taking a little bit of time. But as the risk profile of this drug demands that you get real information, right? That was more than I probably should. I got on a roll. It happens sometimes.
Any last question? One concept, or I would say additional intersection that we saw, I am CEO for the area agency on aging. We saw the extreme withdrawals, like, I'm sorry, opioids are bad, you can no longer have it. I'm sorry, I'm 85, go away. But they literally were cutting off. We were getting calls from seniors, 82, 85 years old, been on medications 20, 25, 30 years, and being told they're bad. The other intersection with that age piece, though, is medications, from what, again, not a clinician, they're not age adjusted. Everybody gets the same dose based on your weight. But we know because of the medications that seniors often take, they don't act the same. And that's often not taken into consideration. You know, we call them the pill purse, you know, when they pull out their bag and put their 47 medications on there. And again, not having those conversations and then no one to advocate for the seniors because seniors, surprise, they trust their physicians and they won't question. And so I think part of maybe our job in the work we do is to teach them to question. And how do you do that from that intersection of age where the trust is so high and B, where you're not the expert and they know they're not the expert. I mean, I experienced it with my dad when I had to sit on a doctor and say, this is what he's taking. This is what was prescribed. And by the way, I don't know what's in this 3rd bag. Would you tell me? Because there just wasn't that intersection. So how, with that intersection, how do we make change in that subgroup of people that there's a different way we have to look at this than just how we look at everything else?
Yeah, it's a really good question. So I think the subpopulation of the elderly is actually super important for opioids. It's important for one, because one of the major side effects of opioids in the elderly is falls, right? So if you kind of want to get a sense of like, what are the negative impacts of opioids, most people prescribed opioids don't overdose on them, right? So the graph that I showed you that's really terrifying, it is in fact terrifying, got way worse during the pandemic. During 2020, the last 12 months up to now, 2020 to 2021, 93,000 people in America overdosed, right? Really, really bad. The vast majority of them were not prescribed opioids and overdosed on the ones they were prescribed, right? But there are still a bunch of negative effects that comes with opioids. So some people do develop an addiction that leads other ways, but in the elderly, the worst side effects is probably falls, right? We have this well documented. So falls are really important. Also, if you have a subpopulation of patients who are in like early stages of dementia, forgetting, right? the easiest way to accidentally overdose is if you've gotten to pretty monster doses and you're on these like 80 milligram oxycodone tablets, you take one and then walk away and like, oh, I should take my pills and take another one. That's a lot of opioids all at once, right? So yeah, so those subpopulations, that subpopulation, I totally agree, needs a lot of special care. To be honest, I don't think that can be solved by the sort of, right now, the way we're trying to address a lot of what I presented to you is like, hey docs, take some CME courses, right? So why do I spend my days going around and talking to doctors? Because everyone needs CMEs on opioids, and this counts, right? I don't think we're going to get the gerontologists, the family docs with the elderly population. Like, I don't think we're going to get them to the level that they actually need to be at without more specialized education. The specialized education is slowly coming, by the way. So I know there are people here in education who'd be interested to hear kind of what's going on. But I teach in a pain course at Hopkins that is new since 2015. So it was not happening when this happened to me, and they started it. And at the end of M1, every medical student takes an immersion course, a week-long course on pain. Is it everything they need to know? Not even close, right? But it's way more than they had before. You could graduate Hopkins. Everyone did graduate Hopkins before that with no formal education in pain medicine, right? And that was just standard, right?
Not seeing any other questions, and I think that was really helpful when we talk about CEC. So on your table, you do have that the directions of how to collect those. So thank you for that. And Bill, will you join me up here for a moment? And we would like to present you with the Sherwood B Winslow Distinguished Lectureship Medallion as the selected speaker for this year. And if we can get a quick photo, and you and Bill for that. Yes, and thank you, Dr. Rieder, and have one more applause for tonight. Thank you. And again, thank you everyone for coming to tonight's lectureship, and those online that joined us. Thank you for being here. Just a couple quick notes as we wrap up tonight. We have in April, we have another lectureship, and it will be with Dr. Caulfield, who has completed research on topics such as stem cells, genetics, research ethics, the public representations of science and health policy issues, and it has published over 350 academic articles. If you would like to join our mailing list, either on your table or at the table that you got your name tag from, we have slips that you can make sure that your name and email address and your home address are all on there, so that we can get that sent to you, just in case you didn't receive one in the mail this time or an email this time. And also thank you to the Doctor Community Foundation staff who have helped with setting up the event tonight, as well as the Cool Center staff who made the room look so great for all of us, and WMed for helping us to bring in Dr. Rieder for tonight and host this event, and also the Winslows, of course, for being such an advocate in this area. So thank you everyone, and I hope everyone has a wonderful night. Okay.